and 3.
Good evening, doctor. You will agree that IBS is a multifactorial disorder marked by recurrent abdominal pain and altered bowel function. Can lead to significant impact on the quality life of the patients.
And 3.
Good evening, doctor. You will agree that IBS is a multifactorial disorder marked by recurrent abdominal pain and altered bowel function. Can lead to significant impact on the quality life of the patients.
And 3.
Good evening, doctor. Further, it becomes more challenging. Is a multifactorial disorder marked by recurrent abdominal pain and altered bowel function. Can lead to significant impact on the quality life of the patients.
And 3.
Good evening, doctor. Further, it becomes more challenging. Is a multifactorial disorder. It is repeating sound.
Santosh, we are extremely sorry. Santosh, you can start.
Yes. Good evening, doctor. You will agree that IBS is a multifactorial disorder marked by recurrent abdominal pain and altered bowel function and can lead to significant impact on the quality life of the patients. And further, it becomes more challenging because of the lack of the simple diagnostic test and wide varieties of treatment options available. So it is our pleasure to have Dr. Parimal Lahate sir as a speaker for today's IBS Charcha. And today's IBS Charcha is based on a case-based discussion on IBS. And Dr. Parimal Lahate sir has practicing experience of 31 years of excellence in the field of gastroenterology. And he is the currently Director Department of Gastroenterology and Liver Disease at Jahangir Hospital and consultant gastroenterologist at Devnath Mangeshkar Hospital, Pune. And he has 20 published, including 3 chapters in textbooks. Dr. Parimal Lahate sir is the organizing chairman of Indian Society of Gastroenterology for the 2021. And we believe this IBS Charcha webinar will be useful in your day-to-day practice. During the webinar, you can post your questions in the chat box. Now, I request Dr. Parimal Lahate sir to start today's IBS Charcha. Over to you, sir.
So, thank you very much, Team Zydus, for inviting me here for this talk. Today, what I have been requested to do is to talk on this novel title called as IBS Charcha. So I hope there's a two-way communication at the end of this and that there's some charcha which happens when we finish our talk. The talk is tailored to practicing gastroenterologists as well as for practicing physicians and surgeons, both primary and secondary care. What I have been told to do is to do a case-based discussion. So there was a long time when we diagnosed IBS by what it was not, in the sense we had to do so many tests and then say that all are normal, so now it is IBS. Now there is a paradigm shift, so that now what we generally try and do is we go by these criteria, which we may not go into details, which are called as Rome criteria or whichever Manning criteria which we use, or the Southeast Asian criteria. And depending on these, so we can think of making a positive diagnosis only on clinical grounds. And an important feature in all these criteria is the presence of alarm features. So if these are present, then of course you investigate those patients, and non-responders you try and investigate at about 4 or 6 weeks. So that's a broad way we look at IBS today, or irritable bowel syndrome today. What I have tried to do is I have tried to take cases which will lead us through 2 or 3 issues. One is, many times you feel that the patient is IBS or has been treated as irritable bowel syndrome. But when you go and dig into the history, you find that it is something else. The second scenario is where you find that it looks like something else, but turns out to be irritable bowel syndrome. And the third scenario is, of course, where you feel it is irritable bowel syndrome and it turns out to be irritable bowel syndrome when you use these criteria appropriately. So today we'll try and touch upon some case scenarios in all these areas. We can go to the next slide. So we have, I think, 3 or 4 cases. So case 1 is a 55-year-old lady who's been a diabetic for 15 years. History of diarrhea, intermittent nausea. Diarrhea was in the afternoon and it's been going on for 8 to 10 years. So diabetes about 15 years and diarrhea about 10 years. Crampy pain prior to defecation, at times it is severe, no nocturnal diarrhea, no alarm symptoms, no recent change in bowel habits. So it has been the same all throughout. The physical examination is normal, and multiple tests she has had, including colonoscopic evaluations, treatment courses, which have included treatment for irritable bowel syndrome, antibiotic courses, probiotic courses, and so on and so forth. Next slide. So issues which come to one's mind when you are faced with this patient with a big file is this irritable bowel syndrome of the diarrheal type. What more can you do by way of testing, or are there some simple screening tests which you can do? Would there be any point in repeating a colonoscopy which has already been done by a qualified gastroenterologist? Next slide. So if you look at this category of functional bowel disorders as per the Rome 4 classification, the functional gastrointestinal disorders are classified depending on which organ is involved. So here we are talking about the bowel. So in this you have, this is called a category C. Of course, you don't have to remember all this. But basically, if you look at it, there are various functional bowel disorders. So one is you can have irritable bowel syndrome. You can have functional constipation. You can have functional diarrhea. You can have abdominal pain, bloating or distension functional. Unspecified functional bowel disorder. And this comes into force because there are a lot of people who have overlaps. Everything may not be fitting and so on. And this is something which is not very common so far in India, opioid-induced constipation. So today what we'll do is discuss about C1, that is irritable bowel syndrome. Now this slide is important from the same angle. So here actually, if you look at the x-axis, the horizontal axis, you have pain which increases from left to right. And if you look at constipation, the y-axis, which is going up, you have constipation which increases. On the right-hand side, the y-axis goes down and there is diarrhea which increases. So on one side, you have diarrhea, on one side, you have increasing constipation. And you have pain which at one end of constipation is almost absent. At one of diarrhea, end of diarrhea, it is almost absent. So if you go to the previous slide. Yeah, so here if you see, now what's the point? A lot of people say, what's the point in differentiating between a constipated irritable bowel syndrome and functional constipation? So the difference, go to the next slide again. So difference is that if you have a patient who has, suppose you concentrate on this IBS-C on the right side, the top column. So there the constipation is high, pain is high, and that is irritable bowel syndrome C. If you look at the other side, on the left-hand side, you have constipation, which is high, the left side, and there is hardly any pain. So that is functional constipation. So if you have constipation, which has a lot of GI symptoms in very simple terms, it is irritable bowel syndrome of the constipation type. And if you have no abdominal symptoms, practically it is just a functional constipation. Now, what's the point in differentiating between these two? Now, many times you use drugs like prucalopride. You use so many other drugs. Now, if you have a patient with irritable bowel syndrome and constipation who has pain and so on and so forth, and you use a drug or a laxative, which is an irritant laxative, which is going to increase the motility of the bowel, that patient's symptoms may worsen. So you can use these drugs very freely in functional constipation, but you have to be careful when you are using them in IBS-C. So there is a practical difference when you are treating these patients, and that's the reason why you need to make these differences. Of course, it is not sacrosanct, so you can have patients who are in a mixed kind of basket, but then you have to go by individual patient symptom presentations. So this slide is very important because it shows that the importance of only constipation or only diarrhea without any symptoms whatsoever is functional constipation to functional diarrhea. And the same symptoms with a lot of abdominal symptoms is IBS-C and IBS-D. Next slide. So this is how you diagnose by the Rome 4 criteria. We won't read them out, but basically, actually, if you look at the last slide, the criteria are fulfilled for at least 3 months with symptom onset at least 6 months before diagnosis. Now, why 6 months? Because if you have a person who is having some disease which is lurking inside, by 6 months of the onset, it is possible that he or she would have developed some alarm symptoms or some new symptoms or some clinical finding or lab finding, which points out to the fact that this is not IBS, there is some disease which is slowly increasing. Next slide. So if you look at this patient, she's been having this for so many years. She has not lost weight. There are no alarm symptoms. So she fulfills the criteria for irritable bowel syndrome. If you look at the frequency, a little bit too high for an irritable bowel syndrome. Generally, it is 3, 4, 5 times a day. But there are no dietary aggravating factors. Lactose also is not a factor. And she has tried withdrawal of lactose on so many occasions and has received multiple medications. Next slide. So what do you do with these patients? So we consider a differential diagnosis always. Now, one possibility is what is called as microscopic colitis. Here, the colon looks normal, but when you take a biopsy, you either find collagenous colitis or a lymphocytic colitis, and it is pretty treatable with budesonide and mesalamine. Budesonide more than mesalamine. Diabetic diarrhea, of course, needless to say, been going on for more than 10 years of diabetes. Bile acid malabsorption or BAD, bile acid diarrhea, BAD as it is called today, is a relatively newer recognized entity which responds very well to cholestyramine. Or could there be some other cause beyond all this? So we decide to, next slide, the options for to evaluate with the repeat colonoscopy, do a biopsy, look for microscopic colitis, try and give cholestyramine and see what is happening. If it is going to be bile acid malabsorption, she may respond. Then evaluate for small intestinal bacterial overgrowth with either a lactulose or a glucose hydrogen bread test, and then give rifaximin as per the findings. But the patient was really not keen on all these tests. So she said, I have had too many of them. You try and give some magic medicine. Next slide. So we went into the history and we found out that she was a diabetic patient, reasonably well controlled, but she was on a dose of metformin, which was almost 1.5 to 2 grams for the past many years. And on retrospective questioning, there seemed to be some overlap in the duration of metformin and her diarrhea. So what did we do? Next slide. We discussed the case with the diabetologist and requested for stopping of metformin and prescribing some alternative to get down the glucose. And to our surprise, actually, her diarrhea practically completely stopped. And she started having a stool frequency of about 2 or 3 well-formed stools per day. Next slide. So one thing you have to remember is when you are making a diagnosis of IBS-D or a diarrheal type of IBS, your chance of being very certain about IBS is lesser than when you are making a diagnosis of IBS-C or constipation. Because here you have a wide differential diagnosis and you have to keep all these. The two very common culprits are olmesartan, metformin, and personally, it is my personal opinion that telmisartan also causes diarrhea in a lot of patients. So definitely look at these causes. Always do a milk withdrawal trial. Keep diabetic diarrhea and small intestinal bacterial overgrowth at the back of your mind. And of course, organic diseases or conditions like we discussed here. Celiac is something which is commonly evaluated nowadays and it's pretty simple to evaluate. Make sure the patient is on a wheat diet and then only do the IgA tests for endomysial antibodies, or as a screening, it is better to do a tissue transglutaminase antibody. So you have to keep this in mind. Next slide. A wide range of drugs, actually, we tend to overlook them, which can cause diarrhea. And one of them actually is not very prominently mentioned here is proton pump inhibitors. So a lot of patients are on an auto mode of proton pump inhibitors. And this thing is a fact which you have to remember and try and stopping them and check whether the patient really needs them. Next slide. So one question which I found helpful in practice over so many years is to try and see what precipitated the event. So if there's a lifestyle change, like change in your house, change in the toilet, change in your job, which has precipitated, there's some stress factor. Onset after travel and diarrhea suggests a post-infective irritable bowel syndrome. If there's a stressful event, this is pretty common actually. Somebody is suddenly diagnosed, he's been getting treatment for so-called gas and whatever, and suddenly it turns out to be malignancy or some such problem. That can trigger off symptoms in some patients, and drugs is something which you have to look for. Next slide. So take-home message of this case is, like we said, we were going to discuss 3 scenarios. One was what looked like IBS but turned out to be something different. So this is a case from that type of that category of cases. So what looks like IBS may not always be IBS. Drug history not to be missed out, and always look for atypical features in the history which may be the clue. Now in this case, the only atypical feature, if at all, was the relatively poor response to a lot of medicines. And the second feature was that the frequency was a bit too high for irritable bowel syndrome. So it is not that an IBS patient cannot have 10 times, but 8 to 10 times does appear a little high for them. So these are things which you have to keep in mind. And so this was the first case where what looked like IBS was not IBS. So we'll go to the next case. Next slide. So this is a 40-year-old man. History of abdominal pain, bloating, constipation for about a year. Symptoms almost every day. A sense of incomplete evacuation, hard stools, on and off. He had diarrhea, so some amount of diarrhea, constipation. Insomnia, fatigue, anxiety related to his job. Marketing jobs, a lot of travel, change in food timings. One day if the person is in North India, the next day in South India, the third in East India. There's a lot of dietary pattern change which happens. No history of alcohol or significant habits. He's a multitasker, which is very common nowadays. I think I would include myself into it. Of course, I don't have IBS. That's a different story. For fear of symptoms, he avoided spicy food. Physical examination and laboratory normal, including a stool examination. When you are doing a stool examination, the most important test to be done is an occult blood. So a lot of people ask for oasis parasites. And when you see a report of oasis parasites, it's okay. I mean, it's not that it's not helpful, but it is better to do a stool occult blood always, because that is something which is really significant. The other test which is commonly done is stool calprotectin. So if you have a person who has some suggestion of of inflammatory bowel disease, a high stool calprotectin, especially more than 150 or more so 250, would definitely point towards inflammatory bowel disease. So remember to do a stool occult blood and routine both always when you're doing these tests. Next slide. So this is a simplified first line algorithm for the diagnosis of irritable bowel syndrome. So recurrent symptoms, bothersome symptoms, like I said, abdominal pain, discomfort are prominent symptoms. And there's an altered habit, which may be either constipation, it may weigh towards diarrhea, or it may be a mixture like a mixed type of IBS. Then you do a physical exam and history. And then if you feel that there are no alarm features and the patient is fitting into a criteria for Rome 4, you make a positive diagnosis of irritable bowel syndrome. Next slide. So there are further clinical aids which you can do. So if you have a patient with a lot of non-GI symptoms like migraine, then dyspareunia, then interstitial cystitis, constant lethargy, aches and pains all over, that again supports your diagnosis. And one important thing is that the pain is somehow related to the bowel movement. So it may increase or decrease. A lot of patients say in the morning I get pain, and once I go to the washroom, I am quite okay. In fact, these patients may say that I am awakened by pain, and you may feel it's organic. But when you ask them, they say that their pain is relieved once they go to the washroom. So these important clues will suggest that this is a functional disorder. Next slide. So the patient, needless to say, underwent all these tests which we just discussed, including an occult blood. Next slide. Now, this is something where it looks like IBS. And looks like IBS, and we put the criteria and it appears to be IBS. So now you have this Bristol stool scale, which everybody should be well versed with. And this is of course there on the net and all articles on irritable bowel syndrome. But very simply, if you have a category lower down, it's a diarrheal stool. And type 1 is a constipated stool. And type 3, 4, 5, you can say is, especially 4, you can say is more or less a desired stool to have a lot of patients. So it depends on how many percentage of bowel movements are loose or watery. And then depending on that, you can categorize these patients. And those who are interested can, of course, see it on the net or can have a screenshot of this. And it is not like 25-50 sacrosanct. It has to be approximate when you are taking the history. Next slide. So we use this pretty commonly in our patients, the Bristol stool scale. And once you start doing it, you find it is pretty easy to apply. And in fact, patients are pretty interested in showing what the stool is like if it is an IBS patient. And there are a lot of patients, in fact, all of us have experienced, who may be taking photographs and showing their. In fact, I've had some patients where the son has said yesterday the stool was of this type, and mother says, no, yesterday it was not like that. So there are two people watching the stool at the same time. So this patient, we made a diagnosis of IBS-M, which is a mixed type of irritable bowel syndrome. More than 1/4 of the bowel movements with type 1 or type 2, which is constipated type, like I said earlier, and about 1/4 which were 6 or 7, which were mushy or loose. So here we make a diagnosis of IBS-M. Now, there are no very good guidelines for IBS-M because here you have a mixture of both. So are you going to give an antidiarrheal, or are you going to give a constipatory agent, or are you thinking of giving a laxative to these patients? Next slide. So how much do you evaluate? Now, like I said, the first patient looked like IBS but turned out to be something different. Here, the patient looks like IBS. We are pretty sure it is IBS. And so how much do you investigate? So this slide, actually, we won't read it out. But this is a slide which shows as to how much investigations you can do as first line, and then make a diagnosis of irritable bowel syndrome. So if you look at the IBS mixed type, we practically did most of these tests and they were negative. And sometimes you can do a plain X-ray abdomen. Our professors used to do it very frequently. And then depending on the stool distribution, you could make out where the stool was located, and they could make some inferences on basis of prevalent concepts at that point of time. Next slide. Next slide. So we decided that, and the patient agreed that he would be willing to have investigations should there be incomplete response to treatment. So this is what we do by counseling. This is a very good article, actually, and I think all of us should be reading this article. I have a feeling it is probably free on the net. You can take this snapshot and you can read it at your convenience. It has very good diagrams and very good tables which you can use in practice. So these are the various ways on the right side I have said, which you can try and tell the patient or explain to the patient as to what is going wrong in his GI tract. So these are the terms which we commonly use in practice, and this is a kind of formal list of what terms you can use when you are explaining to a patient. Next slide. Then there's a new concept which is come especially in Rome 4, which of course all of us do in practice, which is in very simple terms, look at the patient as a whole. So you look at the whole and you do what is called as a multi-dimensional. So here you have all these things like how much is it impacting the patient's day-to-day life? Are there any physiological markers? Are there any psychological markers? Then you try and subcategorize the patient, because IBS is a very heterogeneous disease, and each patient may have a different overlap of GI and non-GI symptoms. So you look at all this as a whole and then think of treating the patient. Next slide. So if there's a patient whose main concern is that there's some major disease going on and he has seen some close relative, such a type of patient, you can do a colonoscopy first, and if it is normal, about 50-50 chance the patient may even get a complete cure of his symptoms. Next slide. So like I've written here, the IBS-M management is not as clear as C or D, because if it's IBS-C, you're going to give some laxatives. If it's D, you're going to give an antidiarrheal agent. So here you check on what symptom is predominant and what is more. Now, like we said in this patient's history, he had a fear that he may have to go to the washroom, and he always looked for places where there was a good washroom, or he avoided going, or before going, he went to the washroom and he avoided going to places where there was some problem with the washroom. So here, probably the main concern was sudden bowel evacuation. Next slide. So in our patient, we did a drug history assessment. We found that he had frequent alternative medicines and so on and so forth. And he was told that he should stick to a regime of medicines for constipation and a diet, and need-based laxatives were prescribed. Next slide. Next slide. So this is also very important. So today, actually, if you look at a lot of IT personnel, and for that matter, a lot of patients, you find that you have these books in the toilet. In fact, I had the opportunity to visit some designer toilets some years back, and there was a full library on the right side of the cupboard which was kept and which the patient used to go through when he was sitting on the toilet. So you have to tell the patient, avoid turning them into libraries. Next slide. This is something which people should be told that is not meant for anything else, but this, I don't know how true it is, but I guess it must be common. Next slide. Next slide. So the other thing we told him, so one was toilet education. It sounds very simple, but it's important to ask the patient and inform him that these are things which, correction of which may help the patient. Then the second is fiber supplement. So here you have insoluble and soluble fiber. So insoluble is generally wheat bran category of fiber, which in trials is not found to be very good. So you should prefer to give soluble fiber. Next slide. The commonest fiber which you get is isabgola, which is a soluble fiber. You can get it plain, you can get it flavored, which you can get it one which is dissolving, and in combination with lactitol. 10 to 13 grams per calorie. So if you're taking an 1800 calorie diet, about 20 to 25 grams of fiber is what is required. Next slide. Now in practice, I have found that this is a very good chart to give to patients, and people can have a screenshot of this, because here you know how much is 1 gram, how much is 2 gram, and then it becomes very easy to calculate 20 grams or 20. So if you ask the patient to take 2 dried figs, it is 4 grams. So plus 1 apple, so 4 and 4, 8 grams. So you know that patient has taken about 8 grams. So roughly you can do a calculation much better than just saying that you eat green vegetables and fruits. Next slide. Now there have been some reviews on this, and like I said earlier, soluble fiber is effective in treating IBS. Insoluble or bran does not appear to have benefit. There is no harm from the intervention, but one would prefer soluble fiber, and the dose would be about 10 grams to 15 grams per serving. Next slide. So in our patient, we started on fiber supplements, and he had multiple visits to the clinic at times every week also, which is pretty common with a lot of irritable bowel syndrome, but giving them time is important, even if it is 5 minutes. And at the end of 1 year of regular follow-up visits, he was better to a tune of about 70 to 80%. One thing which you have to do is, when you are setting up goals for treatment, it is very difficult to tell a patient that, yes, I am going to cure you and you are not going to have symptoms. You should put a goal of about 70 to 80% and say that if it is going to be more than all, it's fine, absolutely, you're happy with it. Next slide. So take home messages. This is a patient of, like we said, what looked like IBS and turned out to be IBS. So a positive diagnosis can be made with the use of appropriate criteria. Rome 4 criteria are very helpful. You can have a subclassification which can help in personalizing treatment. Lifestyle change and counseling regarding the same is very important. And a multidimensional treatment, or looking at the patient as a whole, is very important in these patients. And of course, a patient doctor helps the patient. So you have to give time and not look down upon them when they keep on coming to your clinic twice a week or every week for that matter. So the first case, like I said, was what looked like IBS but was not. The second case was what looked like IBS and what turned out to be IBS. And we had some discussion upon depending on the types and the role of fiber in irritable bowel syndrome. Next slide. So I think you can go to the earlier slide and put the. So this is something which also we tell patients very commonly, because IBS is an incurable condition on Google, but in the clinic, I think there are a fair number of patients whom you can cure and give good relief and satisfaction. Next slide. So this is patient number 3. Pain in the abdomen recurrent for many years, relieved by passing flatus and defecation. Sounds like irritable bowel syndrome. Pain often in the morning, so that again like irritable, and bloating. So he consumed alcohol occasionally, did not smoke. Spicy food suited his taste buds, so he had a lot of it. Modest milk intake, curds being the predominant form, as he had read that it had some probiotic properties. Next slide. Physical exam normal. Like I said, practically everything is normal. So young man, no comorbidities or alarm features, bloating and to a lesser extent, pain being the predominant symptom. So here, what we'll do is we'll focus on this symptom in particular, that is bloating, and how you deal with it in practice. So this is a very common symptom with which patients come to us. Next slide. This is a fairly good classification of bloating, and it is quite helpful in practice. So you check with the patient if he's having bloating and belching. So you have a lot of patients who are loud belchers and they have bloating. So these patients generally have aerophagy and belching. And during the aerophagy, they swallow a lot of air, and that is what really causes the bloating. So if you cure their aerophagy and belching, their bloating automatically reduces. The second thing you look at is whether the bloating occurs less than 2 hours after food, 2 to 3 hours, or after that, or immediately within a few minutes of food. So if it is a few hours after food, you assume that the food has moved into the small bowel, and there's something wrong in the small bowel which is causing the bloating. While it is within half an hour to 1 hour or 1.5 hours, then you consider that this is a gastric bloater. Now, this is not, like I said, watertight, but this gives a good broad line, because a lot of our surgeon colleagues, they ask, what do you all do as gastroenterologists when somebody says that he has bloating? Because so many patients say that I have bloating, पेट फूल जाता है, balloon जैसा होता है, football जैसा होता है. So what you do with these patients? So this is something which you can do in practice. If you have a gastric bloater, you can think of gastric outlet obstruction, etc., or if it's a diabetic gastroparesis, but the commonest cause is functional dyspepsia. If you have a bloating which occurs a little later after food, it is either a dietary factor, a SIBO, or irritable bowel syndrome with bloating, and so on and so forth. So this also is worth taking a screenshot, and you can try using it in clinical practice. In about 6 in 10 patients, you find this formula reasonably helpful to give you a guideline as to how you go about in that particular patient. Next slide. So these are causes of bloating. Some which can be overlooked are surgical interventions. So now you don't find too many of them like gastrojejunostomies, etc. But obesity surgery is something which you have to look for, and so on and so forth. So these are the causes of bloating which are very common. Next slide. So you had 5 Fs, that is fat, flatus, fluid, feces. And I would add the 6th F, which is functional. So functional bloating is the 6th F in bloating, which you should keep in mind. Now, there's a lot of talk on irritable bowel syndrome and SIBO. And this is a summary which I have drawn from a very recent paper in American Journal of Gastroenterology. 25 studies, about 3,000 patients in each group. 4 methods were used to assess small intestinal bacterial overgrowth. One was the glucose hydrogen breath test. The second was a lactulose breath test, methane breath test, and a culture. Sorry for the type errors. It was a culture. So prevalence of SIBO was 33.5 and 29.5 using the breath tests. If you use the lactulose bread test, it gave a little higher SIBO prevalence. In some, it may be about 3.6 fold and 7.6 in controls. Because those who are doing this test, you know that there's a second peak which occurs in the colon, and you already have bacteria there, and the lactulose gets metabolized over there. OR for CO with IBS-D compared with IBS-C was 1.86. Culture-based studies, which yielded about 13.9% in IBS and 5% in controls. Methane positive breath tests were significantly more common in IBS-C. Personally, I don't have experience with methane breath tests, but we do the glucose hydrogen breath test and the lactulose breath test quite frequently in our clinics. So IBS, there is some increase in the people who have small intestinal bacterial overgrowth. The causes for the same are not really very clear, but therefore there is a place of looking for this condition and treating it if it is found. Next slide. The other concept which has come in a big way, especially for nutritionists and a lot of other people, is this concept of FODMAPs. So FODMAPs are basically food items which are fermented, and there's gas production and production of short chain fatty acids. The short chain fatty acids can not only have trophic effects on the colon, but they can have changes in the microbiome, they can increase the osmotic load and so on. And so they can lead to various GI symptoms as shown in this flow diagram. Next slide. There are various ways in which you can look at restriction of FODMAPs. But this actually I find reasonably helpful because it's a pretty simple chart which gives at least the common items which you can avoid when you are telling the patient that you restrict those items. So these, if you kind of remember, it is easy, at least as a first line advice which you can give. Next slide. There are a lot of resources on the FODMAP diet, and I have put some of them. And the Monash one is particularly good, the third one from top, because that was the place where this concept came in, and the first papers really came in regarding FODMAP diet. A lot of these are weighed towards the Western or Southeast Asian type of diet, but you can always look at them and look at what our patients eat and then advise them accordingly. Next slide. This again is a IBS food pyramid because diet is very important. A lot of people would want to know about diet. And here again, we are not going to read into this diagram. But basically what it does is it goes from pyramid kind of situation where the lower bars actually is something which you have to tell to all patients. And then you have to minimize as you go up, above and above. And milk and dairy products, of course, if the patient is lactose intolerant, otherwise you can ask them to take. By and large, if you look at the Indian patients, about 100 to 150 ml of milk in one serving is what most people would tolerate. Beyond that, a lot of people are milk intolerant. Next slide. So this, I guess, we can skip. But these are various carbohydrates which. So carbohydrates, when you're looking at a patient with bloating, the dietary component you need to focus on is the carbohydrates. If you have a person who is having very foul smelling gases, the dietary component you have to focus on is proteins. So that is a broad thing which you can remember from this slide as a take-home message. Next slide. So this is the ESP or 3 steps in FODMAP diet. One is elimination. So diagnose that the patient has improved after the low FODMAP diet. Then you challenge with individual foods and see which are the ones which are the offenders. And then you do a personalization. So those which are not affecting the patient or those which are not causing symptoms, you can ask the patient to restart and slowly build up the amounts. Next slide. So bloating is a common symptom in IBS. Diet plays a very important part in its management. Carbohydrates are the major modifiers, and FODMAP is a new concept which all of us need to get well versed with. You have to have a dietitian involved. The following the FODMAP diet is not very easy, but a lot of IBS patients would do it very happily because they have been suffering for a long time. Next slide. So the third case we saw was a case with a particular symptom of irritable bowel syndrome, namely bloating. And we looked at how long do you continue a FODMAP diet? So normally what we do in practice is we continue for about 3 to 4 months. And then once that is done, and if you're sure that the patient is improving, then we start introducing some of the items and then deciding the personalization part of that ESP which I showed. I think this is probably the last case. A 33 years male, sedentary job, no GI symptoms. So patient has been quite healthy all along and has been traveling and eating in various metro cities, but hardly having any GI symptoms. Then traveled to Delhi in May 2019, ate at a local market which sells regional food. He said he had eaten at Bengali market, which is a famous place where people eat various types of food. The next morning, he developed nausea, abdominal discomfort, bloating pain, and then subsequently had diarrhea of about 6 to 7 grams per day. So on the face of it, a healthy person eats outside, gets an infection, gets diarrhea. Looks like infective diarrhea. Next slide. He saw a local doctor. He was prescribed antibiotics, was better, and the diarrhea seemed to be under control. And then he returned to Pune, avoided travel for a month. And then he consulted for about a month with symptoms of persistent mild cramps in the abdomen, intermittent frequent stools, ill-formed stools, bloating. So this is again a very common scenario where a healthy person gets an episode of diarrhea and then gets persistent symptoms. And then he comes to you for consultation. One thing which is mistakenly done for these patients is to keep on giving repeated antibiotics. So you will find that one person has given him ofloxacin or nidazole, somebody has given him metro, somebody has given him enteroquinol, and so on and so on. And his symptoms are still persistent. Next slide. So physical examination is normal. CRP is normal. CRP is something which is very helpful in practice and not very commonly done. TFTs are very common in people who have constipation and diarrhea, but you rarely find any abnormality contributing to these symptoms. So very rarely you will find in practice that the person is hypothyroid presenting with constipation, or he is hypothyroid and presenting with diarrhea. So it's a test which is often done, but you're very low yield. Rather than that, doing the CRP may be more beneficial. And stool, like I said, always do an occult blood. So he was a well-read man. So he said he wanted a celiac workup, and the tissue transglutaminase IgA was normal. Next slide. So when you have such a patient, there are various differential diagnoses which one has to consider. So persistent infection, Giardia, can be something which is pretty common and which can be overlooked. And a lot of these are not seen on the stool examination. Post-infective malabsorption, secondary lactose intolerance, post-infective irritable bowel syndrome. And needless to say that there can be a new onset disease which has somehow coincided with the patient's travel and symptoms. So it may be an IBD which has started, it may be whatever. So these are the 4 or 5 important things which you have to remember when you have such a patient. Next slide. So how do you go about investigating and treating these patients? So if you have an acute gastroenteritis, if you look at the green people on the right side, most of the people, 80 or even for that matter, 95% would recover whether you give them antibiotics or do whatever. But there is a small subset of patients, 1 in 10 patients or 1 in 20 patients, 5 to 10%, who can have these symptoms which we described. So if you have these patients who have a xylose malabsorption, who have an abnormal fecal fat qualitative, abnormal mucosal histology, abnormal B12. These are patients where you think of tropical sprue. If all these are normal, then you think of IBS. Now, this does not mean that every patient who presents you with the symptoms should have all these tests, but you can look at the patient's MCV. If it is high, it can suggest a tropical sprue. You can do a xylose test, which is pretty simple to do, and we do at our clinic, and it may show that there is a malabsorption. And in selected patients, of course, you can do a mucosal histology, but you could do a celiac workup. When you're doing a mucosal histology, it is the upper GI tract. If you're thinking of celiac disease, we do a 5 biopsy protocol. First biopsies from the first part, and then 4 biopsies from the second part of the duodenum. The logic behind this is that the maximum celiac or the wheat load which occurs is in the duodenum. So it is better to take biopsies from this area. And you should also request your pathologist to look for giardia, because that is something which can get overlooked and which may get picked up when you're doing a small bowel biopsy. So if you look at the patient overall, you find the hemoglobin is normal, MCV is normal, CRP is normal, then you can think of IBS. And not necessarily that each and every patient you document all these things, but ideally one should be documenting, because tropical sprue is a completely curable condition, while post-infective IBS may take a little longer time to respond. Next slide. So this shows what are the differences between post-infectious IBS versus tropical sprue. So normal villi, healthy tight junctions, no or minimal inflammation in the small bowel. There's relatively mild microbial dysbiosis. Very often may respond just to probiotics, while in tropical sprue you need to give an antibiotic like tetracycline, not very freely available, but extremely effective. And in this, of course, the villus crypt ratio will be normal. Here you will have some decrease in the villus crypt ratio, and inflammatory infiltrate would be there, and so on and so forth. So as you go from the left to right, there's a yellow bar below, which shows these things these are the other things which contribute to diarrhea in these patients with tropical sprue. Next slide. So he was advised to stop lactose products for about 15 days. A course of tetazoxanide was empirically prescribed, and he continued to have symptoms. A colonoileoscopy performed was normal. And next slide. So here a diagnosis of post-infective IBS was made. Now this is a relatively newly diagnosed or newly recognized entity. And you have these Rome 4 criteria which are used to diagnose this. So it is not that we gave a clear idea as to what is the difference between post-infective IBS and malabsorption or tropical sprue. One thing which is very important to remember is that a recollection of the precise date of onset. So if you have a patient who says that, yes, I traveled here and after that my IBS started, that's a situation where you can think of post-infective irritable bowel syndrome. Next slide. So this again is a very important slide which I find in clinical practice. So these are very simple pointers which tell you what is going wrong with the patient. And it is important to spend just a half a minute more on the hemogram. If you have a high MCV and this type of history, think of tropical sprue. If you have a low MCV, think of celiac or IBD or some unrelated cause for anemia. Check on the patient's lactose history, because very commonly these patients have lactose intolerance. Look for knuckle hyperpigmentation. If it is there, think of tropical sprue leading to B12 deficiency. If there's low albumin or increased globulin, you can think of malabsorption or inflammatory disorders. If it is increased peristalsis when you are auscultating, lactose intolerance or tropical sprue. And increased platelets, very important. Even if they are more than 4.5, I think of inflammatory bowel disease in this patient. You can make an early diagnosis of these conditions. So these are some simple clinical pointers which you can look at and have some idea as to what this patient could be having. Next slide. So this is a flow diagram for evaluation of post-infectious IBS. So, like I said, we have already discussed this, but basically you try and rule out tropical screw, then lactose intolerance, and so on and so forth, and then make a diagnosis of post-infective irritable bowel syndrome. Next slide. This I think we have almost discussed. Next slide. Yeah, so management of post-infective IBS. So this was for our patients on the right side, where we treated with sustained release mebeverine, and there are some very good products on this available, including from the company for whom I am doing this seminar. Then you can give a probiotic with lactobacillus and bifidobacterium, and this was given for 4 weeks. And the patient, fortunately for us, resolved with probiotic and sustained release mebeverine, and did well for quite a long time. These patients, actually, if you look at it, if there is an anxiety which has crept in because of the patient's symptoms, then there is a role of giving anti-anxiety medicines. But per se, if the person has had a post-infective IBS, this group of patients, they require more of these medicines which we used. You can sometimes give the rambocetron, you can give, or you can give ondansetron as an antidiarrheal in these patients. Probiotic. In some patients, you can use rifaximin. Next slide. So the setting and onset of symptoms of IBS is important. Post-infective IBS is pretty commonly seen. Now, it is always a matter of debate and discussion as to whether you're going to use probiotics first or rifaximin first. I think the price of rifaximin, although it is far lesser in India as compared to the US brand, it is still pretty high. So if you give a 400 milligrams TDS dose for 15 days, the cost comes to around, I think, 2,000 rupees. So it's a pretty high cost. So my personal choice very often is to do the lactose and all that, and then use probiotics, and then for selected patients use rifaximin. Symptomatic treatment is very often quite useful. Antispasmodics, antidiarrheals. If you're giving these medicines and you find that the patient is not responding too well, that's a patient where you can think in terms of doing an upper endoscopy and doing a duodenal biopsy for looking for tropical screw, because it's a completely curable condition. And other thing is equally important, that even IBS, which is post-infective, is a subset of irritable bowel syndrome patients who can get cured permanently. So a lot of IBS is pretty, but like I said, again, I would reiterate here that IBS is incurable on Google, but in clinic, I think a lot of people can be cured. Next slide. So this is a flow chart, which I think if the person who is presenting the slides can enlarge it a little. So this basically tells us a very good, thanks a lot. So one thing is excluding red flag symptoms. So this is very important. Look for weight loss, look for low hemoglobin. So if you have a patient who is having, say, 6 months loose motions and his hemoglobin is persistently about 9 or 10, don't say it is normal. You look at it as a red flag signal and investigate that patient. And very often you'll find some abnormality. Once you are sure there are no red flag signals, you take a history clinical examination. Those things which I showed in the chart, the onset, how it started, a point onset, all these factors are very important. And you can narrow down the differential diagnosis using these simple things in practice. Then you do the row 4 criteria. But basically what it means that it should be there for about 6 months. And 3 months it should be persistent. And then you see whether it is diarrhea or constipation or a mixed type. And that 25-25 rule is approximately there to decide what is going on. Use the Bristol stool scale. In India, it is believed that especially for IBS-C, the Manning criteria may be more beneficial. But then you have to get used to using this criteria in practice, and then it becomes easy to use them. A simple test which you can do is the CRP testing, fecal calprotectin, which also is expensive actually, a celiac TTG test, and CRP. So, and when you are asking for stool, always stool routine and occult blood. And if you have no alarm symptoms fitting into Rome 4 criteria, the basic screen is relatively normal, and those pointers which I said like low HCV, etc., are all normal. You can make a positive diagnosis of IBS. Then, of course, you educate the patient on diet and lifestyle. Use your medications as per the type. Bloating is an important symptom which we discussed, and we dwelled a little on it. You can use all those strategies for treating bloating. Then, depending on which symptom is predominant, this is the drug plan which you can give. A lot of these patients have to be told that the drugs are going to go on for 6 to 12 months so that they are prepared to take the medicine for a long time. A lot of them do very frequent visits, and it can be irritating at times, but I think finally we have to give time to them and see that they get cured. Not all these laxatives are available in India. Some of them are. Like I said, when you're choosing the laxatives, currently the first two which are considered drugs of choice is polyethylene glycol, and the second is fiber supplements. If you have a plain constipation or a functional constipation, irritant laxatives can be used. And IBS-C, who has abdominal symptoms and constipation, may get worsened with all these irritant laxatives, and a lot of them come and tell you that my diarrhea has worsened, my cramps have worsened. So IBS-C, it is better not to use irritant. When you're using crucalopride in IBS-C also, you have to be a little careful and start with lower doses. A lot of them tend to get diarrhea or cramps with it. So that's a minor difference which you have to bear in mind when you're trying to differentiate between IBS-C and functional constipation. Role of anxiolytics is very important, and I have not really discussed much on that. But by and large, most gastroenterologists use a small dose of amitriptyline, about 10, or some of us may use 25. You can use a combination of an anti-anxiety plus antispasmodic. SSRI is very commonly used. So these are drugs which we use very commonly. There is change. There is a change in prescribing practices from gastroenterologists to gastroenterologists. So there are some who use them in all patients, but you can always look at the patients, like I said about the multidimensional model. You can look at it as how much is the element of anxiety. If the anxiety is related to disease, especially only a disease, then a normal test may be curative. If the anxiety has crept in because of the ongoing symptoms, relief of symptoms is more important than the anti-anxiety medicines. And for the others, of course, you can use them. So that's at least what we would do in practice. So with this, I think we can end this talk. Next slide. So bottom line clinical message is very common: symptom-based illness and diagnosed on basis of symptoms. Use your tests selectively. History taking, onset, dietary precedents, lifestyle, how much it's affecting the lifestyle, all very important when you're treating these patients. Actually, once you start doing this, you can finish all this history in just about 7 to 8 minutes. So it is not that you have to keep on talking and talking to the patient for hours or to find out all this. Intervene when the patient is talking only when it is required. A lot of people feel happy when you listen to their whole history. The other trick which I use in practice is there are a lot of people who come with a list of symptoms. So the best thing is to write the answers on the list with a pen of a different color, and they can take it home and read it. So that's the best and quickest way to solve this problem of patients who come with dietary lists. And a multidimensional model or holistic approach, which embraces the patient's lifestyle, diet, exercise, treatment, everything, should be a very helpful modality of treating these patients. Next slide. So I would thank you for a patient hearing, and if there are any questions, we will be happy to take them. I think about 3 to 5 minutes we can take questions if there are any.
Yes, sir. A question is shared with you. Should I read out the questions, sir, one by one for you?
Yeah, I can see them actually in the chat box. I'll go from the lower. Probiotic and rifaximin, of course, rifaximin is an antibiotic. Probiotic is a probiotic, but you can give them together. But rifaximin is not really something which causes a bacteria. It is meant for treating small intestinal bacterial overgrowth. I generally prefer to use them individually, and that probably makes more sense than giving them together. We use probiotics for antibiotic-induced diarrhea and various other things, but this really doesn't fall into that category of indications. About anxiolytics, Dr. Praveen Joshi from Pune has asked. So we discussed this a little at the end. So we check about the role of anxiety in an individual patient, whether it has crept in later, whether it has crept in from the beginning and started the symptoms. So if it is the precipitating factor for the symptoms, then you really need to give anti-anxiety agents. And if there's a strong psychological anxiety, depression, which you diagnose, then you have to give. But for a lot of patients, it may not really be required. At what stage one has to think that it's not IBS but celiac disease? So, like I said, it is more common in the diarrheal type of or bloating type of patients. So here, what we can do is if the patient is not responding, say for about 4 or 6 weeks of treatment, then you can think of treating these, evaluating these patients for celiac disease. About treatment of microscopic colitis, not exactly in this topic today, but the treatment, amongst the two drugs which are very commonly used, budesonide is the one which is evidence-based, and we should use it quite frequently in these patients, and it gives very good relief. By and large, it has to be used for about 6 months for sure. And it's a condition which is commonly seen in ladies about 60, 65 years. And sudden profuse watery diarrhea is what they come with. The colon looks normal, so one has to be vigilant to take colonic biopsy to look for either lymphocytic or microscopic or the collagenous colitis. FODMAP diet, like I said, we generally start and give for about 3 to 4 months, and then do a reintroduction and then the personalization. So I guess, yeah, IBS and superadded IBD. Actually, the reverse is more common. So there are a lot of people who have IBD and who have superadded irritable bowel syndrome. So in fact, just today we did a sigmoidoscopy on a patient who has been properly diagnosed and properly treated for a proctosigmoiditis, which was mild. But he's been having symptoms of increased bowel frequency, urgency, and so on. And we found that his sigmoidoscopy was completely normal because he had been appropriately treated. So in such type of a patient, probably it is the IBS which is the predominant symptom generator rather than the inflammatory bowel disease. So we have started him on treatment focused on IBS. Now let us see how he responds, but hopefully he should do well. A patient with IBS, of course, can develop superadded IBD. Here we look for presence of blood in stools or any alarm symptoms, or like I said, increased platelets or low MCV. All these can be pointers towards an inflammatory bowel disease. So I guess we have probably covered practically. Bile salt test is not really available. We normally give cholestyramine for this patient. Dr. Sanjeev Khanna has asked this. We give cholestyramine to patients who are IBS-D, who have not responded to lactose, you have gone through the drug history. And 1 sachet 3 times, or you can start with half sachet 3 times and increase it. Those who respond, we could consider that this patient has a bile salt diarrhea. So I guess we can stop here, and thanks to everyone who spent their time for this attending this session. And I hope that it was worth the time they spent from their busy schedules. Thanks to Dr. Nandi and team and Zydus team for inviting me here and giving this opportunity to share my views and some personal experiences on management of irritable bowel syndrome. So thank you very much indeed. And I think we can hand over to the organizers. So please take over.
Thank you so much, sir. Thank you so much. Shrikant, can we have the slides, please? So good evening all. On behalf of Zydus, I, Mamia Nandi, would like to thank Dr. Parimal Lavate for his wonderful presentation. It was indeed a privilege to listen to you, sir, on a case-based discussion on IBS. Last but not the least, my thanks to entire participating clinicians, without whom the event would not have been possible. It goes without saying that we continue to rely on your affection and support now and hereafter. Thank you and good night.
Thank you.
Thank you, sir.